Hello, my name is Ernest, and welcome to another episode of the Imperial Sports Knee Meeting podcast. Back in January, we hosted another successful conference at the Royal Society of Medicine, and I know many of you listening were not able to be there. So, what we're going to do for the next few episodes is give you full access to some of the lectures that were given on the day itself by world class speakers. And today's episode, we will be featuring Mr. Kash Akhtar giving his lecture on minced cartilage. And right after the talk itself, we also have an exclusive interview with him that's only going to be available on the podcast platform. So if you're listening to this, I also encourage you to go onto our YouTube channel and watch the full episode, as there will be slides that will make things a lot clearer. And I don't want to interrupt any further. So here is Mr. Kash Akhtar about his take with minced cartilage.
So next we're going to move on to Kash Akhtar, who's going to teach us about minced cartilage.
Hi, thanks Rahul and Chim for having me back. So I'm going to talk about minced cartilage, and I am terribly conflicted because I do some educational work for Arthrex. We've got Top Gun 3 coming up in the summers, aimed at senior post-exam trainees. But the main thing I want to say is two things. One is I've been asked to talk about the technique, so I'm here to talk about the technique. I'm not here to promote it. There's lots of other excellent options we're covering in this session. I use pretty much all of them. And also, secondly, Arthrex, they never paid me. But I do think it's important that we do understand all the available options so that we can make our own judgment and apply it when we're treating our patients. I'll start with the cartilage treatment framework, and I'm going to talk about the 14 factors that matter because outcomes depend on judgment, not just on technique. I'll focus on where minced cartilage fits in and the anatomical considerations, because as you've heard, anatomy often makes a final decision. Then I'll show how I do the technique, and I'll be clear about the boundaries and the limitations. So Tim and I take a knee preservation approach for all the patients that we treat at Cleveland, one that looks at all these factors together. Now, the thing is that ligament, meniscus, and alignment, we're all really good at treating. Cartilage, not so much. It's a challenge. So this is how we think about the principles of joint preservation. You've heard it earlier. I'm afraid there will be some recap. And this is the order that we treat the structures in. And you can see that articular cartilage comes last because it will fail if all these other things aren't corrected. When it comes to cartilage treatment, I conceptually think it's really helpful to think about categories rather than individual operations. So at one end, you've got debridement for symptom control, just palliation. You've got reparative techniques, which are your marrow stimulation techniques, as James mentioned, which invariably involve perforating the subchondral plate, and they will end up with fibrocartilage. Minced cartilage sits in the restorative space alongside ACI, aiming to restore hyaline cartilage. And at the far end, you've got your reconstructive options, which are when you're structurally replacing the problem. When deciding how to treat cartilage, these are all the things that I think about before choosing a single technique, because the main thing is that cartilage restoration is never just about the defect. So always think about the joint environment, the lesion itself, the patient, and the real world practicalities. And once you think of it in these terms and you're just thinking through all these things, then the choice of technique usually becomes quite clear. So where does minced cartilage fit for me? So I see it very much as a restorative option. It aims to produce hyaline cartilage. It promotes and puts viable chondrocytes, autologous chondrocytes into there with some extracellular matrix, and doesn't go through the subchondral plate, which has lots of advantages. I do see intralesional osteophytes, as James mentioned. It's a single stage procedure, one operation. There's no cell expansion. It's cost effective. And for me, in my practice, for small to moderate lesions, where it's purely in the cartilage and not through, I choose Autocart or minced cartilage. And if there is anything that's gone below the subchondral plate, that's where I'll consider AMIC. It is not a replacement for ACI, OATS, or OCA, but the good thing about it, because you're not perforating that subchondral plate, you're not burning any bridges. Those options are still available. And of course, one of the challenges is the biggest thing that I hear is that it doesn't have the long-term evidence because it's not been around long enough. We've got data up to 5 years now, and this is constantly developing. But also, for me, a lack of long-term 10-year data doesn't mean a lack of rationale or logic. But it's the anatomy that really dictates what's possible. So in the patellofemoral joint, osteochondral transfer is difficult, very hard to match the geometry of the donor and the recipient. And for me, I use it a lot in the patellofemoral joint for small lesions. That's why I think it's a suitable pragmatic approach for restorative options. In the femoral condyles, you've got pretty good access, and I'd say most cartilage options are on the table once you're there. But if you want a single stage procedure that doesn't involve violating that subchondral plate, it's an option. If there's any issue in the subchondral, that's where then I will change something. If there's subchondral edema, I want to decompress it by perforating it, and I will drill it and I'll do an AMIC. If there's any bone loss or bone cysts, then that's where you're looking at more of a structural thing. Then you are considering an Oates procedure, an OCA, or even ACI with a bone graft. Containment is really important. For these lesions, just as James mentioned for the AMIC, you want it to be a contained lesion with walls on the edge that will hold things in place. And when you're looking at athletes and people with demand, you're looking at increased load tolerance, you want more durability. And actually, for real elite level athletes, you're probably better off just doing a debridement and doing the minimum amount possible. If there's someone who's more amateur but still putting a fair bit of load through it, I would choose something structural. I might go straight to an Oates or to an OCA if it's a bigger lesion. But in people who have lower demand, lower load on it, then it is definitely an option. But often, as I mentioned, the strategy gives you the framework, but anatomy makes the decision. So just a little animation here. We've seen where minced cartilage fits. The next question is, how does it actually work in practice? I just want you to keep three things in mind: containment, lesion preparation, cartilage handling. You can see this is a contained defect. There's walls around the edge of it. And so what you start off doing is you want to debride the edges of that cartilage and make nice smooth walls. You collect it in this sieve. And this is the technique I use. And then you mix it with some PRP. You create a paste. And it's all autologous. Now, this animation is wrong. I wouldn't perforate the base ever. And then you put it in place. You fill the defect, not overfilling it, ideally to about 60 to 80%. And then you put some fiber glue on top. So that's the concept. Now I'll show you how I do it. So my setup is I was ever side support, and I use a foot ladder for most operations. I like to take the knee through a range of motion and put it in different positions. So when I start, I'll do my standard, I do use vertical portals, so I do my standard arthroscopy. And actually, if ever I'm going to do a mini open, I quite like having the vertical portals anyway, because you can just extend it and do a little approach. I can do most of these now arthroscopically, but the patella in the patella, I would still like to do it a mini open because it's up on the ceiling. I don't want, I worry about gravity. So the first thing you do is put a shaver in, and you want to get the fat out of the way, just because you don't want it in your way so you can see. And secondly, I don't want to get that when I'm collecting the cartilage. That's the defect there. This is what the MRI had confirmed, a full thickness cartilage defect, big flaps. And this was a personal trainer, couldn't work. Even bodyweight squats past 80 degrees causing pain. So I'm going to do an Autocart. So we open this thing called the graft net, which is a sieve to catch it. You connect it between the suction and your shaver, and I change the blade over now to a different shaver blade to collect the cartilage. And so I'll start now harvest and collect. And you can remember in the olden days, if you're just doing a debridement, this will just go in the bin, it'll go in the shaver, disappear. So for me, I'm collecting these cartilage chips. Because we're doing an Autocart, I've now activated the anaesthetist to start taking blood for the PRP. So the anaesthetist is doing that while I'm doing this, and that's being collected. It goes over there. You get your 3 syringes. The fourth thing is a counterbalance, and they spin it for 1500 RPM for 5 minutes to create your PRP. Well, that's all happening while I'm doing my thing. Now, if you look to the main picture here, just from that one lesion alone, I've been able to get a lot of cartilage. My big fear at the beginning was, when I started out, was I wouldn't get enough. And you can go around the intercondyle notch, you can go to the edge of the trochlear, but look, all of that is just from that one cartilage event. This would have gone in the bin. And so, I can leave a hole, or I can choose to fill the hole. So that is what has come out of that. I'm now doing my arthrotomy. I'm sorry, it's the first time I wore my meta glasses. I didn't know about the glare. So, but I'm just doing a little approach there, extending my portal to invert the patella. The PRP is being drawn up, as you can see on the side over there. And there's a lot of stuff happening on the back table. And so there's the PRP coming in. And so you need your reps to help you. And all that magic happens on the back table. They don't normally aware of it. You take 3 or 4 mils of that, stick it in this thing called the thrombinator, because you want to make some fiber glue for later. The nurse is going to shake it hard for 10 seconds. It's much quicker at Cleveland. The nurses are very effective. And then they just lay it down flat. And then you put a couple of drops of that into your cartilage paste, and with your cartilage chips, and you create this paste. It's all autologous: patient's cartilage, patient's blood, patient's PRP. Here, what I've done is I'm now just correcting the base of it and confirming the edges, and I'm drying the lesion. It's got to be dry. And then I come over here. Now you can see me in stereo. And so what I'm going to do is just collect that paste. I'm going to put it into this introducer. This is designed for arthroscopic use, but I quite like it even for doing a mini open. And so I'm putting the paste in there. Autologous cartilage chips, autologous chondrocytes in there, PRP. She's breaking up the thrombin clot over there whilst I'm doing that. And I'm just feeding this into the stylet. And then I'm going to come in, because the glare, I've put a picture up at the top. You can see you just put it in there. You're going to fill it to about 60 to 80%. You don't overfill it. And just pat that down. And this is when I first started mini open. This is on a femoral condyle, just to show you one I did there also, that you can see this is the chips and the paste going in, and it's not, you don't want to fill it 100%. It's really tempting to. And then you get the thrombin, which comes in, which is an enzyme in there. And you put a couple of drops of that. You can just see it top right, just kind of coming down. And the last thing is a bit of fibrinogen. And that substrate acts with the fibrin to create fibrin glue. And then you leave that for about 2 minutes. And actually, you can cycle it through a range of motion. It's dry at this point, no fluid. But you can take it through a range of motion, and it's stable, and it sticks. So to finish, minced cartilage is just one tool in the toolbox for the selected patient. In my practice, it is for small lesions, contained defects, preferably most so in the patellofemoral joint, but I've used it on femoral condyles quite a bit. But it's not the solution for everything. Expert cartilage surgery is bespoke surgery, choosing the right intervention for the right patient, lesion, and anatomy. And for knee preservation to work, it's important to create alignment, stability, and meniscal integrity. But it's definitely another option in our toolbox for me. Every life deserves world-class care. Thank you.
So welcome back to the Imperial Sports Knee Meeting. I've got Kash Akhtar with me. And thank you so much for your talk on minced cartilage. It's obviously an area that is up and coming. And I just wanted to ask a little bit about what you did on there. So do you just take the flap away, or do you have to take away like a rim of normal cartilage as well to be able to cover that defect?
So when you're looking at a cartilage defect, cartilage brings the smooth lining at the end of the joint, and there's disrupted cartilage and there are flaps. What you'll do is, often we'll do a procedure called a debridement. Historically, you would just take the edges away, and that kind of disappears in the shover and goes in the bin. And for me, that's a rich source of autologous cartilage, chondrocytes, and it has extracellular matrix. So what I'll do is take the cartilage flaps, stabilize them, and you will take a little bit around the edge as well, so you can have vertical walls. It's almost this analogy like if you've got soup and you're putting it on a flat plate, it's going to roll off. But if you've got it in a bowl with edges, it stays, and it's what we call a contained defect. So you'll contain that defect, you'll collect that cartilage, those cells, there's a viable chondrocyte. So you'll mix it with PRP you take blood from the arm, mix it in a centrifuge, take the PRP, create a paste, and then you fill that paste back into the defect, and that fills up.
Right. And have you ever gone back into the knee to actually have a look at what happens to it?
So not often, because in my experience, it's worked well, so I've not often had to. But if I've done it, for instance, a patient's I'm doing a 2-stage revision ACL reconstruction. I've done the cartilage defect at this time of the first surgery, because I know I'm going back in 6 or 12 months later to do the ACL. And I've had a look, and probably been in 3 or 4 times, and I've been really impressed. It's filled in beautifully. You can't see the joints. And as a standard practice, we do PROMs, and we'd follow outcome scores of patients pre-surgery, and then 3, 6, and 12 months post-surgery. And I'll do an MRI scan at 12 months. I've been really impressed with the MRIs because it's autologous, because it's cartilage. It's not microfracture. It's actually what we call type 2 cartilage, high-line cartilage, normal cartilage. You can't even see the joint. And on the MRI scan, it just looks beautiful. It makes your heart happy.
Good. And I assume that the patients are asymptomatic from it as well.
So the results have been great. I'm really impressed. I want to say minced cartilage is a procedure for a very specific group of patients. It's got short to mid-term data. It hasn't got the long-term data yet. And there are the techniques, and we use all the techniques. So there's also autologous chondrocyte implantation. There's oats, we take a plug of bone and cartilage and plug it in. There's osteochondral allograft, we take a big plug from a donor. So we use all the techniques, but I've been using minced cartilage for about 4 years now. Really impressed with it so far. There's good data being published for 2 years, coming up to 5 years. We don't have the 10-year data yet, and so we're waiting on that, but we're collecting our data as well and contributing to that.
Sure. And just one last question for me. I know you mentioned that the specific patient group you are looking at is patients with smaller sort of cartilage lesions. Is there any sort of indication that you could use it for larger cartilage lesions?
So I think you could, but I think you're then really pushing the indication. So 2 by 2 centimeters, a 4 centimeters squared is probably the largest I would go. And that's probably the same, because that's what it was for microfracture, for AMIC. That was kind of considered the cutoff. Anything beyond that, purely cartilage, one would go for cell-based, like ACI. And if it was into the bone, then you would do a couple of oats plugs or an osteochondral allograft.
Lovely. All right. Thank you so much for your time.
And it's a pleasure. Thanks, buddy. Thank you.